Some of his chutzpah. This one has been replaced by a muffled, cautious demeanor.
In draft power of containing authorizing for the Palisa are transparent.
Good morning.
Hi, good afternoon. Or good morning to you. How are you?
Sorry, I forgot. Good. Yes,
problem.
good afternoon to you.
Hi, Prof. You're speaking to Dr. Leonard. I'm just running the Zoom. Dr. Muchabi is just logging in. Thank you very much for joining us.
Oh, happy to. Thank you for the invitation.
Thank you. You are welcome to start screen sharing as soon as you'd like. I think she'll be joining us in 2 minutes.
Okay. So you're having your session. This is your department anesthesia rounds, is that correct?
Yes, this is our afternoon academic meeting with our whole department.
Very good. And how do you manage to all get out of the operating room at 2 p.m.?
So we generally have an agreement that only emergency lists continue after 2 p.m. on a Wednesday. It's our agreed upon meeting time with our different hospitals.
Oh, very good. Very good. And how is your work now different than a year ago with respect to COVID?
Prof, yeah, so it was very, very quiet for a while. There was quite a severe lockdown that we had here, and a lot of our work is unfortunately alcohol and trauma related, so that was very quiet for a period.
Okay.
It's gone back to normal from that point of view. Our elective lists have resumed. We seem to be at the sort of trough of our COVID pandemic at the moment. So it's basically just universal pre-op testing and enhanced PPE. But other than that, we're pretty much doing all lists and things as we used to.
That's exactly where we're at right now. We were extremely slowed down in March and April, but now we're back up. We're actually working a little harder than we used to. We're doing elective lists on, Saturdays, for example, that we didn't used to do because of a backlog from March and April when we were so slowed down. All the elective cases are COVID tested. They get nasopharyngeal swabs the day before. But the emergency cases are not. So we have various levels of PPE that we use, and I assume that you do too, in the COVID unknown patients.
Yes, that's exactly how we're doing it as well. And we are able to get some rapid COVID swabs done in a few hours in emergency cases that need to go to ICU, etc. There I see Dr. Mochabi has joined the meeting.
Wow, what a great picture.
Memories.
Yes.
How are you? They
Very
locked me
good,
out of the meeting. I blame Tristan.
Sorry, Palesa.
It's good to see you.
They locked me out of the meeting. Good to see you. Thank you so much for joining us this early Canadian morning. I just wanted to bring up this picture. I'm sure the registrars know some of the people, and they don't know one person. I was actually looking for a picture of you in theater at the Gen with a shoe boot on your head because we didn't have caps. No, I can't find the picture, but I will be sure to have it when we do the update meeting, because my registrars don't believe that you have walked the grounds of our hospitals. So welcome, thank you so much. Thank you so much for doing this for us. And thank you for agreeing to be part of our update meeting later on in December. We're looking forward to hear like the godfather of thoracic surgery, anesthesia. So to the registrars, this is the Peter Slinger. I was asked if it's the Peter Slinger. Yes, this is the Peter Slinger. The Peter Slinger of the three-legged stool. Welcome. The platform is yours. I'm going to take off the picture so you can picture, or you can say a few words. You can, yeah. So whenever you're ready, I don't know if you wanted to say anything, but yeah, we're just chuffed to have you.
Oh, well, thank you very much. And I just want to mention that when you emailed me last night, my time, about your cardiothoracic seminar for registrars, it just occurred to me, what a good idea. Why don't we do the same thing in Canada, like have a nationwide 1 day cardiothoracic? So I'm going to steal your idea. At least I'm going to suggest your idea to some younger people who I
Thank
think will be
you.
very interested. Okay,
Yes.
now I just want to get my screen full screen. There we go.
Yes.
Can you all see my screen?
Not yet.
No?
Mm-mm.
Okay. Uh,
Prof, I think if you just select screen share again.
At the
okay,
bottom,
I
yes.
somehow lost the screen share. There we go. Yep, I'll try that. How about that? Can you see that?
Yep, we can see that.
Oh, great. Thank you. So, and now, are you still seeing?
Yes.
Okay. So what we have there is a picture of a double lumen tube with a bronchoscope through the bronchial lumen. And when we look through the bronchial lumen, we see the whole world. Pardon me, that's my hemisphere, but the whole world. I'd like to talk to you this morning about lung isolation and spend some time talking about lung isolation for thoracic surgery in a patient with a difficult airway. And when we talk about lung isolation, difficult airways are a common theme in anesthesia, but when we talk about thoracic anesthesia, we have to consider both the upper and the lower airway, because lung isolation involves both parts of the airway in thoracic surgery. I'll talk about the ABCs. What I mean by the ABCs are just the basics of lung isolation. And then I'll talk about some new equipment that we have available to us. So here we have 2 chest x-rays of the same patient. On your left is a patient. She's a 75-year-old woman, and she's had a right pneumonectomy. This is post-op day 1. This is a normal post-pneumonectomy film. That's an empty right hemithorax and a normal left lung. She had a 4-hour operation, minimal blood loss, and she's very comfortable on day 1. Now, she does very well for the next 5 days. However, on day 7, very suddenly, she starts coughing up massive amounts of serous fluid, and she becomes severely hypoxemic. Here we have her chest x-ray on day 7. You probably can't see it very well, but there are some air fluid levels now. What's the diagnosis? She's extremely dyspneic. Her saturation's 80% on air. She's breathing at 30 a minute. She's sitting up. Well, the only thing that really fits with this, I mean, many things could cause sudden dyspnea, pulmonary embolism, myocardial infarction, but the only thing that really fits with this picture of sudden onset of dyspnea and a profuse cough really is a bronchial pleural fistula, and in this case, dehiscence of her bronchial stump. Registrars will see many bronchial pleural fistulas in their career in anesthesia. Most of these will be subacute related to infections. They get admitted to hospital, they get medical treatment. If medical treatment fails, they come to the operating room. The principles are the same, basically, in managing all bronchial pleural fistulas, and we'll talk about that. However, when a bronchial pleural fistula occurs immediately in the acute post-op period after a pneumonectomy, it's life-threatening. And this patient's going to have to come back to the operating room now. And when we get her to the operating room, for the surgery to happen, we'll have to have some form of lung isolation. Now, we always have 3 choices for lung isolation. We can advance a single lumen tube as an endobronchial tube. We can use a double lumen tube, or we can use a bronchial blocker. So it's going to have to be one of these things we do for this patient. Now, in this picture, on the top is a standard single lumen endotracheal tube. As I said, it can be advanced as an endobronchial tube. In the yellow circle here, There we've got the cuff, the Murphy eye. So it's about 4 centimeters from the distal orifice in an adult tube to the proximal end of the cuff. Now this will barely fit in the left main stem bronchus. On the right side, it actually will obstruct the right upper lobe. So you can use a standard endotracheal tube as an endobronchial tube in an emergency, but it's not the ideal device. There are specifically commercially made endobronchial tubes. Here's one. It has no Murphy eye. It has a very short cuff. It's flexible. It can be used as an endotracheal tube and then advanced over a bronchoscope and be used as an endobronchial tube. We use these tubes for surgery around the carina. They aren't widely available, but this kind of tube would be a very acceptable choice in this patient. Most anesthesiologists use double lumen tubes for lung isolation. Now, the original double lumen tube, and this is a picture of it and a diagram, is the Carlin's tube. I don't know if you're familiar with Carlin's tubes at all. Carlin's was not an anesthesiologist, and he wasn't a surgeon. Carlin's was a respiratory physiologist in Sweden, and he designed a tube to be placed so he could do lung separation studies. He was assessing tuberculosis patients to see if surgery would be acceptable or not based on split lung functions. He designed a tube that had 2 cuffs, a tracheal and bronchial cuff, 2 lumens, a bronchial and tracheal, and it had this hook on it to sit at the carina. Now, the problem with Carlin's tube, Carlin's not being an anesthesiologist or a surgeon, just took 2 single lumen tubes, stuck them together. It worked for his purposes in the laboratory. It really wasn't an ideal anesthetic device. High flow resistance, very difficult to suction secretions through it. So there were subsequently many different designs, and ultimately the design that succeeded was based on work by Robert Shaw, who was a British anesthesiologist in the 1970s. Now what he did is he designed a tube. It's not really 2 circular lumens, it's actually 2 D-shaped lumens, like in the center of this picture, fused together. These are actually very low flow resistance tubes. And he designed right-sided tubes for left-sided surgery, and the right-sided tubes have this ventilating side slot to ventilate the right upper lobe, and then left-sided tubes for right-sided surgery. All of our modern double lumen tubes are based on designs by Robert Shaw in the 1970s. Here's a couple of commercial left-sided tubes. These are now obviously disposable, made of polyvinyl chloride. Now, you can't always use a double lumen tube. Here's a case that might relate to your practice. A 20-year-old is involved in a motor vehicle accident. He's unconscious, he's intubated at the scene. It's uncertain if he has a neck injury, so a cervical spine collar is then placed. When he gets to the emergency department, he's shocky and there's no air entry in his left chest. They put in a left chest drain and immediately a liter of blood comes out. So they begin resuscitation, then bring him immediately to the operating room for a left thoracotomy. The surgeon asks for lung isolation so he can find the injury and repair it. Now, this intubated, unconscious young man in a cervical collar, you probably don't want to change that endotracheal tube that's in place for a double lumen tube. So here's an excellent case for bronchial blockers. Do you have any bronchial blockers available to you? Maybe we can talk about this later, but I'd be
Not
curious.
always.
Not always,
Not always. In
unfortunately.
private practice, yes.
Well, bronchial blockers are really useful devices in trauma. Now, the original 30 years ago, we used to use Fogarty catheters, Foley catheters as bronchial blockers. They didn't work very well. In the early 1980s, the Univent tube was designed. It's you probably are not familiar with it, but it's a single lumen tube that has a bronchial blocker built in a separate channel on the inside. I don't really like the Univent tube. It's a very stiff tube. Often we're using bronchial blockers in patients with difficult airways. So not a great option. And again, you'd have to change the tube in this young man that we talked about with the head injury. So in the 1990s, George Arndt, who's an anesthesiologist in Wisconsin, United States, designed a disposable bronchial blocker that could be used through any standard endotracheal tube. So if your patient's intubated, you can now have lung isolation. Now, in his design, initially he designed this odd sort of oval-shaped cuff. The very good thing in his design is this three-way connection. So you can see here we've got our circuit, we've got our bronchoscope, and we've got the blocker, and this is a Borscht connector. You can tighten it down to hold the blocker in place. Now, the thing that I don't like about Arndt's design is the loop. It's got this loop that you slide the blocker down over your bronchoscope. In the picture, it's like a fireman sliding down a pole. I don't know if that makes any sense to you in South Africa. Traditionally in North America, firemen lived above the fire hall where the trucks were, and at night they slide down a pole rather than run down the ladder. So it's sort of a probably North American specific reference. Anyway, there's issues with this loop I'll get into in a minute. Now, because the Arndt blocker is not a perfect blocker, there have been many other designs. This is the Cohen bronchial blocker. The Cohen blocker has a wire, and when you turn the proximal wheel, the wire flexes and you can flip the blocker, turn it, hook it one way or the other, left or right main stem bronchus. And then Fuji, who make the uniblocker, which is that single lumen tube with the blocker inside, sells the blocker separately. And they call it the uniblocker. You see, it's got a fixed hockey-shaped design. In Canada, we love hockey. So very popular blocker here. And you simply, there's no wheels, there's no loops. You just turn it one way, turn it the other to get into whichever main stem bronchus you want. Now, we've had these three blockers in North America for 15 years. Now, there's a fundamental difference among them, and that's, as I said, the Arndt blocker has this loop, and you slide your blocker, you get your bronchoscope where you want it. Your bronchoscope is basically the delivery device, and then you slide the blocker off. And you don't see the blocker until it's actually off the end of your bronchoscope. Sometimes this blocker can get stuck here at the carina, but you don't know where it is. You can't see it. I don't know if this clinical situation ever occurs to you. Are you ever do a fiber optic, say a fiber optic intubation with a single lumen endotracheal tube, and you get the bronchoscope through the cords, but then when you go to advance the tube, it gets stuck. And if you've done fiber optic intubations, you're familiar with this. It's not infrequent. And then you fiddle the tube, you twist and turn, and usually it goes. Well, the same thing happens here. You fiddle, you twist and turn, but it is annoying. These other tubes, you're actually advancing the blockers, you're actually advancing the blocker ahead of your bronchoscope. So you see where you're going. It's just like turning the lights on in your car at night. As you see in the picture here, we've got a blocker going into the left main stem bronchus, and here in the diagram, the blocker ahead of the bronchoscope. Now, sometime in your career, you'll have to get lung isolation in a patient who has a tracheostomy or a laryngectomy. This is always a cause of concern. Blockers are ideal here. This is a review article from the Journal of Cardiothoracic and Vascular Anesthesia by Dr. Campos last year. He reviewed their experience at his hospital over, I think it was approximately 100 different cases of lung isolation in patients with tracheostomies. And basically recommended, if it's a fresh tracheostomy, so it's in place for less than 2 weeks, you simply use the tracheostomy device. But if it's a mature tracheostomy, you should remove the tracheostomy device and replace with an endotracheal tube, and then put your blocker through an endotracheal tube. With an endotracheal tube, it's a little easier to position the balloon or the cuff of the device than with a tracheostomy device. Now, what if the stoma is small? that you can't get, a standard endotracheal tube big enough to fit through it. Well, one option is to use a blocker outside your endotracheal tube. Blockers can be placed through the end of the endotracheal tube, but they can be placed external. I don't do pediatrics, but I know that the pediatric anesthesiologist, this is often an option in small children, that you intubate first with the blocker and then follow with the endotracheal tube. So here we've got, this is the Fuji blocker going through a tracheostomy stoma here, and we've also passed an endotracheal tube. Then we put the bronchoscope through the endotracheal tube, and we can position the blocker. This happens to be an armored flexible endotracheal tube, but any endotracheal tube works. And when we inflate the cuff of the tube, it holds the blocker in place. Now, what if it's a very small and fresh tracheostomy? Well, when we talk about the size of tracheostomies, the common things you hear, this is a 6, this is an 8 tracheostomy device. That's the size of the internal lumen of the internal cannula. In this case, a 6, and that's a common size of a tracheostomy. Now, you can't get a pediatric bronchoscope and a bronchial blocker through a 6 lumen, but what you can do is you can remove the inner cannula, and that gets you an extra millimeter of diameter. And then you can connect with, this is just a standard 7 millimeter endotracheal tube connector. And then you can usually get a blocker and a pediatric bronchoscope through the device at the same time. Now, one complaint that many people have or worry about bronchial blockers is that the lung doesn't collapse very well. Many surgeons believe this, unfortunately. So we decided to test this. What we did was we actually did a study, and we used 3 kinds of bronchial blockers and double lumen tubes, left-sided double lumen tubes. And the surgeons were blinded to which device we were using. We chased them out of the operating room during intubation, and we put a sheet over the patient's head. So they didn't know if it was a bronchial blocker or a double lumen tube. And then when they opened the chest, we asked them how collapsed the lung was. And the lung collapse score, they rated it from 0 to 10. 10 was complete collapse. Now, when they opened the chest, here we've got in yellow, this is an ARNT blocker group, and green is a Cohen, blue is Fuji, and red is double lumen tubes. You see, they're all 60 to 70%. There's no statistical difference here between the groups. They're all about 60% collapsed when they open the chest. They're all about 70% collapsed at 10 minutes. They're all about 80% collapsed or 90% collapsed at 20 minutes. There was no difference. The surgeons could not guess if we were using a blocker or a double lumen tube. There are a few, what I call tricks, clinical points when you use a blocker. One thing is to ventilate with 100% oxygen for 5 minutes, if possible, prior to inflating the blocker cuff. Because once you inflate the blocker cuff, any gas trap distally here has to be absorbed. And as you know, oxygen is much more soluble than nitrogen in the air. So if this is all oxygen, it gets absorbed more quickly and the lung deflates more quickly. A prolonged expiration, what I do is actually disconnect my anesthetic circuit and basically just let the end-tidal CO2 go to 0 over 20, 30 seconds, and then I inflate the blocker cuff. And then, of course, you have to do a recruitment maneuver to recruit the other lung. All the new blockers have a suction channel, and I put suction -20 on low suction until the lung is well collapsed. Pressure control ventilation. You maybe use pressure control ventilation all the time. I don't really generally have much preference between pressure control and volume control ventilation. But if you do use volume control ventilation and the patient coughs, then air gets forced around the blocker cuff and the lung reinflates. And then the lung can't deflate because the blocker is like a plug in a sink. Okay, so you have to deflate the blocker. So it's just pressure control ventilation is easier. And if you warn the surgeon, if you say we're using the blocker and the surgeon manipulates around the hilum a little more gently, there's less chance that the blocker will dislocate, and they tend to pop up above the carina and the lung reinflates. Now, In the same study of lung collapse, we actually looked at this question. Does the blocker move during surgery? And unfortunately, the answer is yes, it does. So there's 26 patients in each group, and this is the number of times after surgery had begun that we actually had to reposition the blocker. So about 2/3 of the time with the ARNT blocker, about a third of the time with the Cohen and Fuji, very rarely with double lumen tubes. So I'm not saying that double lumen tubes never move, but they move less frequently than blockers. So this is still a problem with blockers. So if you just need lung collapse for the surgeon convenience, and that's a big reason, but if that's all you need, blockers work very well. But if you're worried because you've got blood or pus down in the lung and you want to protect one lung from the other lung, you're much better off still with a double lumen tube. Now, we studied, by the way, this was the original elliptical ARNT blocker. The company now has discontinued this and now just produces a spherical blocker like the others. We didn't study that. So it might work better than the original that we studied, I can't say. Now, this is my personal favorite blocker. It's the Easy Blocker. It was designed in the Netherlands about 10 years ago. I don't know if you're familiar with it at all, but it's basically it's got two lumens on it. It's got basically two limbs, and it's got blocker cuffs on each limb. So when you position it, you don't know which limb is going which way. It sits like this on the carina, okay? And there's a yellow limb and a blue limb, and then you put your bronchoscope down and you see which one went which way and you adjust it. One thing about this blocker is that once it's in position, it won't block the right upper lobe. If the right upper lobe is normally, the right upper lobe takeoff is where it should be. So that's nice. You can't push it down one way or the other too far. The other thing is I personally feel that it's a little more stable than other blockers and less likely to dislocate. So I think it's actually more fiddly than other blockers. It requires a little more patience, a little more fiddling to get it into ideal position. But once you get it into the ideal position, I think it's a more stable blocker. But having said that, the majority of my colleagues do not agree. We have several blockers available when people want to use a blocker. And the majority of my colleagues at the Toronto General Hospital still prefer the Fuji blocker than this blocker. So now, I want to get back to what I talked about as the fundamentals of lung isolation, the ABCs. A is know your anatomy, B is use a bronchoscope always, and C is look at the chest imaging yourself always before you start a thoracic surgery case. Now, anatomy. I know that you know tracheal and bronchial anatomy because that's what you do for a living. You're all anesthesiologists. I was very surprised to see this article from the University of Iowa a few years ago. The lead author, Dr. Campos, was actually studying his own staff. And he wasn't actually testing their knowledge of bronchial anatomy. What he was testing was whether they should use a bronchial blocker or a double lumen tube. So he randomly assigned his whole staff, like consultants, registrars, to do cases. He'd say, you're going to do this case with a left-sided double lumen tube. You're going to do that case with a bronchial blocker. And then he was the judge. He'd come in the room, they used a bronchoscope, they positioned the device, and when they were completely happy, they called him and he let them know if it was properly positioned or not. And he found that there was a 38% incidence of major malposition. Now, this wasn't just fiddly little things. This was, say, a left double lumen tube in the right main stem bronchus placed by a consultant, and that consultant was ready to start the case. So he thought that they just didn't know bronchial anatomy. Well, when I read about this, I thought, well, the University of Iowa, it's somewhere in the middle of the United States. They're the people who voted for Donald Trump. We can do better. So we studied our staff at the Toronto General Hospital. We did something much similar, but much simpler. We just made a quiz, a 16-question quiz. This is one of the questions. So in this yellow circle, there's some of the normal airway anatomy, a picture of something. What's in that yellow circle? Is it the right bronchus intermedius, the left upper lobe bronchus, the left main stem bronchus, the right middle lobe bronchus, or the right upper lobe bronchus? Unfortunately, I don't have a way of polling you. So you're going to have to keep your responses, I guess, to yourself, or you can write them down and give them to Palessa at the end of the case, and she can score you. Okay, that's the left upper lobe bronchus. That's a normal appearing left upper lobe bronchus. How could you possibly know that's the left upper lobe? Well, these are, first of all, we have a major carina here, okay, and segmental divisions on both sides. So this is not the primary carina. You may see a right upper lobe, but you don't see segmental divisions on the left side. So this is a secondary carina. So now we know it's a secondary carina. Is it the left side or the right side? You see these white lines here, all going down here? These are the longitudinal elastic bundles. They go down the posterior wall of the trachea. Next time you do a bronchoscopy, look, posterior wall of the trachea, they split, they go down the posterior wall of the main stem bronchi, and on the left side, they all go into the left lower lobe. Very, very useful landmark. So if that's left lower lobe, then that's left upper lobe, okay? Well, what I found was exactly what they found in Iowa, that even our own staff didn't know their tracheal bronchial anatomy very well. So we have developed a website, thoracicanesthesia.com, or if you just Google bronchoscopy simulator, it'll take you to our online free, you don't have to sign up, there's no password even, bronchoscopy simulator. You drive the bronchoscope by clicking on these lighted arrows at the bottom right, and little labels come up. If you click on the label, it tells you what you're looking at. And on the left, it's like a GPS map of the tracheobronchial tree, and the orange line is the bronchoscope. I think it's a good way to review and teach bronchial anatomy. Now, this has been online now for 13 years. I hope you're familiar with it. If not, please feel free to use it this evening and look at it. For the first 2 years that it was online, we forced people who wanted to use it to take the bronchoscopy quiz, the 16-question quiz, before they used it. And these are the scores. This is actually several thousand people over 2 years. And these are the tests they do, the 16-question quiz, before they use the simulator. And I've broken it down. Yellow is junior anesthesia residents, green is senior anesthesia residents, blue is staff anesthesiologists, red is staff thoracic surgeons. And you see everybody's sort of 40 to 50% correct. And then we ask them to do the quiz again after they'd used the simulator, and everybody's increased their scores by about 15%. This doesn't look wildly impressive, but because we had several thousand people, it was highly statistical significant. Everybody improved. So I was very encouraged about that. Then we did ask people to come back 3 months later and do the quiz again. The first time they did it, we didn't give them the correct answers. The second time, we did give them the correct answers. And when they came back at 3 months, the results were sort of surprising. The junior anesthesia residents had actually, I don't know if you can hear my dog barking there. Sorry. I'm at home this morning. The junior residents had actually dropped off, and the senior residents, they were about the same. The consultant anesthetists were about the same. And the staff surgeons had significantly improved their score. I was encouraged that the surgeons got better. It means you can still teach them, which to me was a good point. Now, A is anatomy, B is the bronchoscope, C is the chest x-ray. Now, bronchoscope, use a bronchoscope all the time. Here's a chest x-ray of a patient who's got a cancer left upper lobe. And the surgeon plans to do what's called a sleeve resection. Now, I'm not sure if you're familiar with this operation, but the surgeon plans to remove the left upper lobe en bloc with a piece of left main stem bronchus, and then re-anastomose the left lower lobe to the left mainstem bronchus. Surgeons do this more and more because they want to avoid doing a pneumonectomy, lung-sparing procedures. They found out that the long-term survival and lifestyle of patients, particularly elderly patients after a pneumonectomy, is not great. So they'll do whatever's possible to save functioning lung tissue. And this is one of the things. Now, my question is, if the surgeon wants to do this procedure, what device do we use? Well, we really can't use a left-sided double lumen tube because that's where the surgeon is working. And we also can't use our left bronchial blocker. So we really don't have much choice. We have to use a right-sided tube. Do you ever use any right-sided tubes? Well, there's a few things to learn. There is a learning curve with right-sided tubes. Here in the diagram, we've got a right-sided tube. And these are several commercial right-sided tubes that we have here, okay? They're all slightly different in their design. They all have a ventilating side slot to ventilate. That's a Mallinckrodt, a Rouge, a Sheridan. They've all got this ventilating side slot to ventilate the right upper lobe. Now, chest X-ray. Look at the chest imaging yourself. When I'm going to use a right-sided tube or blocker, I always look at the chest X-ray and I actually measure. These are two different patients. These are coronal section CTs, and I'm measuring the right mainstem bronchus. Here on both, it's about 2 centimeters. Now, if the right mainstem bronchus is 2 centimeters or more, a right-sided tube or blocker works very well, no problem. If it's 1 centimeter or less, a right-sided tube or blocker does not work very well. Now, many patients you'll find are between 1 and 2 centimeters. Now, if it's between 1 and 2 centimeters, a right-sided tube or blocker will work, but the margin of safety positioning it is very small. So it's a fiddle to position it, and you have to watch very carefully that the tube doesn't move when you change patient position or during the case. Now, in the diagram, this is a right-sided tube, and we've passed the bronchoscope through the tracheal lumen. So there we've got the carina. This is right mainstem bronchus, and the tube is actually going to the right mainstem bronchus, left mainstem bronchus. It's a little artistic bridge of secretions there in our picture. Now, here we are, we're going down the bronchial lumen. And what we have here, we've come looking out the end of the bronchial lumen. That's right middle lobe, and that's right lower lobe. Now, this carina between the right middle and lower lobes, this is a very, very important landmark. The whole key to positioning right-sided double lumen tubes is finding this carina and orienting it, because the right upper lobe takeoff is at 3 o'clock. So if this is 9 o'clock, this is 3 o'clock, the patient's in the supine position here for reference, then we know where to look for the right upper lobe. So we pull our tube back until this is that carina, right middle lobe, right lower lobe, and we're looking now at the ventilating side slot. When we rotate our tube, we start to see a little bit of the right upper lobe takeoff, and then we're able to actually find the whole right upper lobe. The right upper lobe, as you see in this picture here, is trifurcated, okay? Nothing else in the airway is trifurcated. So again, very, very useful landmark. Now, very common mistake I find that people make with right-sided tubes is that they push the tube too far down. And so here we have again, this is right middle lobe, right lower lobe, and the D-shaped carina. Sorry. Now there we've got right middle lobe, right lower lobe. Now this is a tube that's too far down, and we've got disoriented. So what we're actually looking at here, this is now the superior segment of the right lower lobe. This is very confusing. Look at the top picture and look at the bottom picture, but there's a very important clinical difference here. This is just right lower lobe. This is right middle lobe and right lower lobe. So you have to always maintain your orientation when you're passing the bronchoscope. Anterior, posterior. You see, this is anterior, this is posterior, but down here, this is posterior, this is anterior. This is a common mistake, positioning right-sided tubes. Now, this is the patient we started at the beginning of this session. Now, this is the 75-year-old woman, and she's got a bronchopleural fistula. Now, we need lung isolation. So what do we do? Well, first of all, our anesthetic goals, remember, are protect the healthy lung regions, okay? Avoid tension pneumothorax, ensure adequate ventilation because we don't want the air going out the low resistance fistula if we ventilate the patient. How do we do this? Well, this particular patient needs a chest drain before induction of anesthesia. If we place a chest drain, we are not going to get a tension pneumothorax. So we've taken one of the three considerations out of the equation. Now, to achieve the other two, we have to get lung isolation before positive pressure ventilation and before we reposition the patient, because that's when she's going to contaminate her healthy lung. So how do we do that? Well, in this case, our only options are a single or a double lumen tube. We really can't use a bronchial blocker in this patient because the surgeon is working here on the main stem bronchus. So single lumen tube on the left, double lumen tube on the right as an endobronchial tube. Either choice is quite acceptable. Whichever you want to do, whichever you have available. Both very good options in this case. My question is, how do you get the tube you want in this patient? If you can picture, this is an elderly woman. She's sitting bolt upright now on the operating table. She's got an oxygen mask on and breathing a high FiO2 or SATs are 80%, and she's breathing about 35 a minute. How are we going to intubate this patient and still respect our goals? Well, are we going to do this awake? Are we going to do this with spontaneous ventilation or some version of rapid sequence induction? Now, I mentioned awake and spontaneous ventilation. To me, they're sort of historical anecdotes. This is what is in many of the older textbooks of anesthesia, talking about patients with bronchial pleural fistulas, awake or spontaneous ventilation for induction and intubation. This is before they had good bronchoscopes. But now, if you have a good pediatric bronchoscope, what I do is a version of a rapid sequence. But what I want you to show you here is my version of the rapid sequence. And I've loaded the bronchoscope into the bronchial lumen of the endotracheal tube, and we're going down the left main stem bronchus under direct vision. So we've pre-oxygenated the patient. We've done a rapid sequence induction. We've intubated with the bronchoscope in the bronchial lumen, and we've gone down the left main stem bronchus under direct vision. Okay, and now our tube's in the left side. We can immediately go to left lung isolation. We inflate the bronchial cup. We've protected that lung, and we can reposition the patient. This directed endobronchial intubation is very useful. Here's a case. This is a patient who previously had a right upper lobectomy for cancer, but now her cancer has recurred in her right middle and lower lobe. So she's coming for a completion pneumonectomy. Now you can see that because of the scarring from the previous surgery, her trachea is very deviated. We want to use a left-sided double lumen tube in this patient, but how do we get the tube to go into the left main stem bronchus? Now, if you do this blindly, and I usually pass these tubes initially blindly and then check with the bronchoscope. But if you do blindly in this patient, it was going to be very, very difficult. So what we do again is the same version of the bronchoscopic directed intubation. So we get our tube down here. As you see in the picture, we're actually got the bronchial lumen sitting at the carina. And now what I'm going to do is I'm going to have my assistant press on the trachea and push the trachea as far. We're doing this in an asleep patient, by the way, because this is very uncomfortable if you do it to somebody awake. Push the trachea as far over to the right as possible. And what this will happen is the carina will shift to the right, and we're able to advance our tube down the main stem under direct vision. This is what we want to avoid. This is the face of the enemy. Okay, this is a tear in the left main stem bronchus, okay, created by a double lumen tube, okay. This, fortunately, is very rare, but is also very well described. There's probably about 100 cases in the literature tracheal and bronchial injuries from left-sided tubes. If you read the case reports, they're mostly about elderly patients who are short, who are female, who are having esophagectomies, who had previous radiotherapy, and difficult placement of the double lumen tube. However, forming a clinical impression based on case reports can be misleading. I've had this happen twice in my career, and neither of my cases fell into any of these categories. One time it was simply that the person who was assisting me, for some mistaken reason, decided to inflate the bronchial cuff with 7 mils. They got confused between the bronchial cuff and the tracheal cuff with a double lumen tube. They put 7 mils in the bronchial cuff, and we tore the main stem bronchus. Fortunately, the surgeon was able to repair it without incident. And the other time was a fairly young, sort of 20-year-old person who was having a lung transplant. And I was having some difficulty getting the left sided double lumen tube in the left main stem bronchus. And the surgeon said, "Here, let me show you how to do it." And he then proceeded to push the tube through the bronchial wall. However, he was the one who then had to repair it. So it does happen. Now, I want to spend the remaining time talking about patients with difficult intubations. This 62-year-old man, he does not look like a difficult intubation. If you ask him to open his mouth, he's Mallampati zero. I mean, he could swallow an orange. He's got his own teeth, but no problem there. On the right is his chest x-ray. And you may see that he's actually got an abscess in his lower lobe. So he got a cancer. He got pneumonia. He didn't know it was cancer. He got pneumonia. When the pneumonia resolved, he was left with an abscess, had a bronchoscopy, and he's got an obstructive cancer of his left lower lobe. So he's coming for a left lower lobectomy. Now, really wanted to do this with a double lumen tube. One of my colleagues induced anesthesia, and this man put in the standard direct laryngoscope, could not see any glottic structures. So he simply woke the patient up. That's how I got involved. Now, this man, he's a very nice man. He does not complain about anything, but his C-spine is completely immobile. He has osteoarthritis. He really can't move his neck at all. And my colleague just missed this. And, you know, most of us get fooled by somebody like this. You know, we can't be too smart about this. Somebody like this in our career. Okay, so the problem is immobile C-spine. Okay, really want to get a double lumen tube in this patient. How do we do it? Well, 15 years ago, our only option was a fiber optic intubation with a double lumen tube. Now here we've got a pediatric bronchoscope on the left, push through a double lumen tube. On the right, it's Ron Peruganin, one of my friends, demonstrating on a mannequin. This is what we used to do. Pediatric bronchoscopes are not designed for this. They're not long enough. They're not rigid enough, but we used to do it. It was sometimes a struggle. But now we have video laryngoscopes. I hope that you have a video laryngoscope or more available. Video laryngoscopes are the major advantage in airway management in the last 20 years. This is just a summary of a hospital experience in the United States where they had failed direct laryngoscopy and 94% save rate with video laryngoscopy, a 94% save rate. That's an amazing save rate. The glide scope's 94%, Kawhi Leonard's free throws, he's 85%. I don't know if you follow basketball, but Kawhi Leonard, the year before this, was a forward for the world champion Toronto Raptors. And he is arguably one of the few best top basketball players in the world. Unfortunately, last season, he moved to another team. Now, glide scopes and double lumen tubes. I've had an issue placing double lumen tubes with glide scopes. The double lumen tube curve is not designed for the glide scope curve. So I used to fiddle, like try and make them fit. This is the study that one of our fellows and I did. And we actually asked our junior anesthesia residents to intubate patients with normal airways who are having thoracic surgery with a double lumen tube using a glide scope or a video laryngoscope. They had much more problem with a video laryngoscope than they did with a direct laryngoscope. So it's not an easy thing always. The company has designed specific guides, introducers for glide scopes, but still I find it's not always that easy. So what I've gotten used to doing is with a glide scope to get a single lumen tube in somehow, awake, asleep. Then if the patient's not asleep, and ask that we put the patient asleep, and then we do a tube exchange. We have these green tube exchange catheters, and here we are looking now. We always look with the glide scope, the old tube comes out, okay? And there's their tube exchange catheter, and now the new tube goes in. And you'll see that it goes in quite easily. It just slides in there, no problem at all. I am not trying to make this look hard. This can sometimes be very awkward, okay? And it's just not me that always struggles. This is a study from one hospital in the United States, and they looked at a lot of tube exchanges, single to single, single to double, double to single. Usually they work very well, but they had a 40% failure rate, as I just showed you, single lumen tube to double lumen tube. Now, different companies do different things with the distal ends of their double lumen tubes. This is a Rush. Rush is our standard tube where I work, and this is what we were using. This is a Mallinckrodt. This is a Fuji. Fuji makes a double lumen tube, and it's got a very, very soft tip, and it's got this bevel on it. And now we're going to do the tube exchange, again, using the Fuji. And it is much more compliant, and it's slightly easier to get in. So now get a single lumen tube in somehow, and then use the video laryngoscope and the tube exchange, and hopefully one of these, a tube that is designed for the purpose. Now, I have to say, there are many designs of video laryngoscope on the market. The original design, the glide scope, had this hypercurve blade that you see on the left. Now, some of the designs are basically the old Macintosh laryngoscope with video, and these are the line of sight blades. And I'm still learning which blade is best for which patient, okay? So if you're using the line of sight blades, like a Storz CMAC, you do not usually have to do this tube exchange. Usually, as you see in the picture here, you can get the tube to go in directly. But the thing is, like, not every blade is suitable for every patient. I find if it's a patient like I showed you with the very immobile cervical spine or a small mouth, the hypercurved blades like glide scope are better. But if it's a very obese patient with a very big tongue, then the direct view laryngoscope type blades, the CMAC, are slightly better. Now, here's a final case to talk about. One of my colleagues was in the anesthesia clinic, and she saw this 69-year-old woman who's coming for surgery next week for a right upper lobectomy done thoracoscopically. Patient had severe rheumatoid arthritis and complained of neck pain on extension. So my colleague very wisely got flexion extension views of her cervical spine. And what you see here in the yellow circle, this is C3 subluxing on C4. So she's got an unstable cervical spine, and she's scheduled for surgery next week. Now, what do you do? How do you manage this airway? Okay, well, my colleague called me. I was in the operating room, said, this is this case, what do you want to do? And I said, refer to a neurosurgeon. In my career, I've never figured out which of these cervical spine surgeons repair or not. Sometimes they do, and sometimes they don't in some complex neurosurgical decision-making that's beyond me. However, in the context we work in, she had to go to another hospital to see the neurosurgeon, so this delayed everything, took a week. She saw the neurosurgeon. In this case, he looked at the x-rays, looked at the patient, and said, be careful. That was it. So now, 2 weeks later, I'm doing the case. So how do we do this? Okay, unstable C-spine, right upper lobectomy. Well, what I did, there are several options here, but what I chose to do was we actually did a fiber optic awake intubation with a single lumen tube, and then we positioned the patient for surgery awake. Lateral position, got her completely positioned that we were not going to move her again, and then induced anesthesia, and then passed bronchial blocker through the single lumen tube. And we did her right upper lobectomy. And then we woke her up, but we didn't move her again until she was wide awake and she could protect her own cervical spine. So, in summary, for lung isolation, patients with difficult upper or lower airways, we have new equipment, particularly video bronchoscopes. If you have a video bronchoscope, both the person who's manipulating the bronchoscope and the rest of the team can see what's going on. And as I was saying, sometimes they can do things to help you, like manipulate the trachea. Video laryngoscopes, there are many new kinds of blades, and we're still learning which blade's best for which patient. There are new bronchial blockers, and there are modified double lumen tubes. But at all times, when we're doing lung isolation, the ABCs apply. And the ABCs are: know your anatomy, use the bronchoscope, and look at the chest imaging yourself. And that basically is the end of my talk. Let's see, I'll get out of here. And
Thank you, Prof.
okay.
Are you trying to unshare the screen?
Yes, I'm trying to see you. Good.
Okay. I'm
There.
trying. Okay, there we go. Thank you so much. Before we open for questions, I just wanted to acknowledge Professor Langren. Hi, Professor Langren.
Hi, Palesa.
Okay. Professor Slinger, I'm sure still remembers you if your camera is working.
Hi.
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 Good to see you.
Hi. Nice to see you too, and a lovely talk.
Well, thank you very much.
Okay. I would like us to open for questions. Anybody on the floor to ask questions for Professor Slinger on this fantastic talk? Yeah, it's very technical, but the one thing I want to say is I'm sitting listening to all the studies that were done, and I would like to steal back the studies and repeat them here. So I'm thinking we can do this and we can do that. So I am going to steal a lot of studies from you, and I'll communicate with you. Any questions, everybody? Part 2. Oh, Silvio, not you yet. Can we have the registrars ask questions first? I'll recognize you, Silvio. Registrars, you only get to ask Professor Slinger questions once.
So tell me what sort of equipment you have available for lung isolation. What are you usually using? So
we have double lumen tubes, certainly. On and off, we would have occasionally bronchial blockers. I can't remember what that thing is that you were showing.
The easy blocker with the tube?
The easy blocker you get in private practice. It scares me a little bit because I'm never sure, like you were saying, which side which is going to, and you blow up and then you ventilate and you're like, oh, okay, I think maybe I've actually isolated to manipulate, and you want ease of just introducing and then isolating the lung. But in the public sector, we don't have a lot of these amenities and the equipment. So most of the time we teach our registrars